an R01 HRQ funded study using a cluster randomized controlled trial design to test the effectiveness of mobilizing older adults via systems-based intervention, MOVIN. Dr. King, along with her colleague, Dr. Lindsay Stiggy, created MOVIN to address barriers nursing staff experience that prevent them from getting adult patients up to walk during a hospital stay. Older adults, in particular, experience significant negative functional outcomes during hospitalization due to a lack of ambulation. As an expert in qualitative methodology using grounded theory, Dr. King has also conducted numerous studies investigating nurse decision-making to mobilize patients, the impact of hospital-based fall prevention strategies on nursing practice, and ambulation recovery in older adults post-discharge. Dr. Lindsay Stiggy is a professor and Gulbranson Chair in Health Informatics and Systems Innovation in the UW School of Nursing. Dr. Stiggy's overall research goal is to improve health, safety, and performance of health professionals, and by doing so, to benefit society by improving healthcare quality. In pursuit of this goal, Dr. Stiggy leads an interdisciplinary research team using multiple methods and applying human factors and ergonomics engineering methods to the analysis and design of healthcare systems and measuring and modeling safety, well-being, and performance outcomes of health professionals. She's also interested in the design and implementation of systems-based interventions to improve health professionals' communication, teamwork, and decision-making processes to improve patient outcomes and quality across healthcare settings. Dr. Mary Hook is a research scientist and nursing research manager for Advocate Health, a large 67-hospital integrated healthcare system in the Midwest and Southeast. She has extensive clinical informatics, evidence-based practice, and research experience, with several studies focused on nurse-led mobility in acute care, including serving as a co-investigator with the MOVIN study. And finally, Sherry Martin is a patient care manager on an inpatient acute care cardiac unit for Advocate Health. She's led her unit in implementing nurse-led mobility with the MOVIN study with sustained improvements over the past 2 years. At this time, I'll turn over to the presenters. If you have any questions or comments, please use the raise hand features and wait to unmute at the end of the session, and we will call on you. You're also welcome to put your thoughts into chat during the session, and we will get to them after the presentation. Thank you so much. Now to turn it over to our speakers.
Thank you, Felice. We are very excited to be here to present. We're really excited to be presenting with our research partners from Advocate Aurora Health. They helped us figure out how to do this at the beginning of the pandemic and carrying this all the way through to where we are in current time. So Molly, I believe you are going to advance the slides. So if you could advance our slide to the first one. So Felice talked about this a bit when she was reading our bios. We have decades worth of documentation that identifies that hospitalization is often a negative event for older adults. They come in functional in their ability to complete activities of daily living and ambulating across a small room independently. And within a short 2 days of their hospital stay, they become dependent in one or more ADLs and no longer able to walk independently. So there's been some interesting ways that this has been now new terms that have applied to this phenomenon over time. Earlier studies back in the 1990s talked about this being functional decline in older adults. Now what we are seeing is terminology that I think really speaks to what's happening to older persons, one being trauma of hospitalization, identifying 4 critical issues, lack of sleep, lack of nutrition, decline in functional status, and increased rates of depression and anxiety that are occurring directly because of how we're providing care during a hospital stay. And post-hospital syndrome, which looks at that carryover, what's happening 2 to 4 weeks out post-discharge, and again, seeing pervasive problems with functional decline, the impact of lack of sleep, and malnutrition being the 3 predominant components. Now, we know that over 50% of older adults will experience what we now identify as a hospital-acquired disability, because that disability occurs from the point of admission to a hospital and discharge is when we're tracking when these losses are occurring. You can give me the next slide, Molly. So what is happening with ambulation during a hospital stay? We have solid evidence that shows that limited patient ambulation and enforced bed rest are the most predictable and preventable cause of loss of ambulation ability in an older adult population. We also have decades worth of work that has quantified using research grade sensors and accelerometers that have shown that older adults spend 83 to 100% of their time in bed during a hospital stay. And the data that was looked at, well, how much time do they actually spend spread and walking, identified that it's only about 4% of the time during their hospital stay. And loss of hospitalization is associated with multiple negative patient and organizational outcomes. So we see much higher mortality rates in an older adult population. We see significant increases in falls, both during the hospital stay and in the first 2 to 3 weeks post-discharge. Patients aren't very happy when they come in functional and now they're being discharged newly dependent or having to go to a skilled nursing facility to get rehab because they're not strong enough to go home. We see a 22% increase in new nursing home placement rates. We definitely see an increased length of stay because of this phenomenon. And we also see increased readmission. If you could give us the next slide. So what's been done? We've been trying to attack this issue over the last 3 decades, specifically looking at functional decline in hospitalized older adults, and concerning with all of the different types of interventions we put in place, we really haven't moved the needle much to improve what's happening to older adult patients during their hospital stay. There have been significant limitations on both current and past research, and we looked at all of the different interventions that were being launched and tested to prevent functional decline. Many of them were single provider focused. Some of them were just physical therapy focusing. Sometimes individuals use mobility teams. The VA has a STRIDE program where they have, when hospital transport staff are not busy, they go up onto different wards and get patients up to walk, but it's only certain patients that are allowed to walk. There's been protocols to guide nursing practice that usually get enforced initially, and then that dwindles and dies off. And the data collection has been primarily by self-reports of function. So using a Barthel index or a CATS ADL index or a self-report of function of how much patients walked or patients reported function of how much they walked or can walk. Next slide. So given that we see this wide berth of what's interventions that have been tried, we stood back and said, well, these aren't working. So why aren't they working? And I had preliminary data. I had data from my dissertation study, which started to identify how nurses were making decisions about whether or not to get patients up to ambulate. And we were able to identify substantial system barriers that were getting in the way of nursing staff ambulating patients. And the focus was on nursing staff because nurses have been identified as the healthcare provider in acute care areas that are responsible for maintaining and promoting patient functional ability. So Lindsay and I blended our expertise. So I came on board as faculty, Lindsay came on board as faculty, and I said, hey, I have this data, I have these results, and we should be able to figure out a better way to get patients up, to overcome these barriers to get patients walking. So we started looking at what we could do and blending our interdisciplinary expertise. We started looking at a systems-based model, which was a systems engineering initiative for patient safety. That was telling us what in a healthcare system that needed to be addressed in terms of the nurse's workflow so that nurses could engage patients in ambulation. But it didn't really address how we were going to impact behavior change. So to do that, we used social cognitive theory, and we blended both of these frameworks together to help guide the structure of our mobilizing older adults via a systems-based intervention, or MOVIN. It was fun working with Lindsay when we first started doing this with great gigantic whiteboards, because we would sit there and look and draw and think about, well, what do we have here and how do we use SEEPs, and what about balance theory, and how do we then integrate social cognitive theory until we could come up with a structure that we thought we had something that we were ready to test. We also wanted to look at multiple ways of gathering data, because the vast majority of early studies on functional decline in hospitalized older adults were using performance-based data, were not using performance-based data, they were using self-report. So it became critical for us to think about, well, how do we capture performance-based data? And then what type of mechanism do we want to use? So we thought about using a gait speed, because it is a gold standard in thinking about physiologic functional reserve. And that would tell us a lot about what was happening during the hospital stay. And it's something that we can track post-discharge. We wanted to be able to mine data in real time. And that would be, how do we then harvest the power of the electronic health record to try to track both frequency and distances that nursing staff were reported in terms of patient ambulation. We wanted to think about healthcare utilization as a critical outcome variable. So we're tracking length of stay, but we're also tracking, where do patients get discharged to? And then, are they coming back from the hospital? As another secondary measure, we started tracking the rate of falls that were occurring during the intervention, and post-intervention. But what was glaringly missing also from the data was, how do we think about value, particularly how do patients identify the value of ambulation during their hospital stay? Next slide. So this is MOVIN. It is a multi-component intervention that addresses 5 critical variables that are barriers to the nursing staff in getting patients walking. From my data, we knew, and from the data that had been published in other studies, we knew that nurses were not confident in their ability to determine ambulation status and getting sick patients up to walk. So we had to figure out, how do we do that? This is a social cognitive theory component. We thought about, well, we'll do a psychomotor skills training. We want to partner with physical therapy to think about, how do we increase nursing staff confidence. We knew that there was little opportunity, both or availability of both patients and nursing staff to get patients walking. So we had to think about, how do we address that by looking at resources, by adding additional staff and ambulation equipment on the unit, so that when a patient was ready to walk and they needed an assistive walking device, that device is readily available, and not having to be ordered from central supply. 2 hours go by and now the opportunity is passed. We knew that we had a big problem with communication. What we learned from another study is that information that's charted in the electronic health record around patient ambulation is generally inaccurate. So we had to figure out, well, how do we address that issue? So we looked at gathering electronic reporting as a way to add a feedback mechanism to the nursing staff on how well they're doing. We had to think about verbal communication tools, as this is how nurses were delivering accurate information about patient ambulation. And then how to improve interdisciplinary communication around ambulation, both during interdisciplinary rounds, and improving the communication between physical therapy and nursing staff regarding patient ambulation. We really needed to think about the ambulation environment. Could we create mechanisms where we could put distance markers in as a rapid way for nurses to calculate how far they were walking patients? So we were thinking about that. We also were thinking about, can we use whiteboards as a communication and ambulation environment component to improve the flow of information between patients, families, and nursing staff and other healthcare providers around patient ambulation. And then we knew we had to shift this unit culture. We had to move the culture from one of ambulation restriction because of fear of falls on the unit, to ambulation promotion, and to a sense that getting patients up to walk were a high priority and a standard of care, and not an issue of, that's nice, I'll get to it when I actually have an opportunity. So I'm going to turn it to Lindsay for the next slide.
Yeah, so thanks, Barb. So I'm going to just briefly hit one more thing kind of about MOVIN and how we built it, especially since this is a D&I seminar, and then briefly take you through our journey. Sorry, do go to the next slide. So as Barb was mentioning, MOVIN is a systems-based intervention, and this seed and soil metaphor wasn't a part of our plan at the beginning, but it sort of came about. So people kept asking us, okay, what's the intervention and what's the implementation, and kind of trying to draw parallels to a lot of what's done in implementation science. And I know, at least as the systems engineer on the team, I really struggled with that because I was like, it's all there. So we found this article that I think has really resonated for us, that a lot of times we think about implementation as figuring out how to make the context or the soil like more hospitable, more accepting of what it is that you're trying to grow, make it all fit together. MOVIN really, instead, from the get-go, thought about the system and thought about human factors. It's really grounded in those disciplines and focused on creating a better seed. So in a way, the soil, we already built MOVIN for the soil, for the hospital nursing unit context. So when we say building better seeds, that's what we're talking about throughout this presentation. So in other words, many common implementation strategies from implementation science are already in those 5 components of MOVIN in how they were designed. And then when we bring MOVIN to any unit, which we'll hear more soon from our hospital partners, it is a very participatory process of launching this intervention. So throughout, we are taking our components, we have our built-in implementation strategies, and we're really refining how that happens with nursing staff and leadership directly on each unit. So if you can go to the next slide, and I'm just going to buzz through this. This is just for a couple of examples to kind of try to illustrate that. So again, for each MOVIN component, and we did this retrospectively. Again, we didn't do this at the outset. We designed MOVIN, as Barb said, from SEEPs and social cognitive theory. And then when people were asking us about implementation, we sort of had an aha moment where we realized like, a lot of these things are already in there. So for example, on psychomotor skills training, we already have some implementation strategies built in on how we train and educate the key partners in the design, develop relationships between them, and then adapt and tailor to context. And then on the far right column, we have some really specific examples of what this looks like with MOVIN. So I'm not going to go through all of these in the interest of time, because I do really want to get to our partners. So if you could skip to the next slide, but we have this mapping of the implementation strategies that are already in the components and the examples of that for each of our MOVIN components. And I'm sure Barb and I would be happy to talk about that more to anyone when we have more time. Next slide, please. So now we're just briefly going to talk about, so that's MOVIN, and then what's happened, what this program has moved through several stages along our research journey. So we started off at the very beginning, I think 2014, with a feasibility study at one unit at UW Health. We used some internal funding. And if you go to the next slide, we were just wanting to see, can we actually build these 5 components? Can we work with nursing staff to implement them all at the same time? Does it work? Can it be done? And then does it have any early effect or look like it might help with ambulation? So there's a lot happening on this graph, but I just really want to highlight that each of the sort of x-axis points there is a month. They start in early 2014 and go for about 3 years. And we saw that when the intervention happened, which is on the left there in a little black sort of marking, the frequency of ambulation by nursing staff went up significantly and then kept going. That's the green line. It was a significant shift, as well as the distance ambulated. These are reported in miles per month. So that also went up quite a bit. So we were like, this is great. We did it. The staff didn't revolt, and we saw some good preliminary data on ambulation. Next slide, please. So then we had our first partnership with Advocate Aurora Health, and we're going to hear more about that. But we're curious. We had a funding from ICTR for a D&I pilot grant to see could we replicate that? And could we have the clinical team on the unit maybe take more of a leadership role in implementing MOVIN themselves? So on the next slide, briefly from that grant, we had questions about could we take this from truly like academic, our partners across the street, and move it to a hospital that's not affiliated with the university directly, a community hospital, and could the clinical team take more of a leadership role in implementing? And the graphs are very small, but I will say that, again, we had a significant shift in both the frequency of ambulation occurrences by nursing staff and then also the distances. And it's hard to see, but at the very bottom, we also looked at what was happening with physical therapy to see if their activity changed at all, and it held steady. So this truly is impacting nurse-led ambulation, which was the goal of the intervention. In doing this, we had created a toolkit. We worked closely with the unit. They were able to implement, but they needed more coaching than we expected. So it started to invite some new questions on how could we better predict readiness, not just for the intervention, but to really manage the complexity of this systems-based intervention. Next slide. So then, sort of in parallel, this shows this linearly, but it was a little bit more curvy than this. We were curious, so we've got a lot of attention here on what's happening with the staff. Is this working at a system level? And we're interested to see if there were patient perspectives and also to learn more about from sort of a leadership perspective, like what would it take to scale this and disseminate this more broadly? So I'm going to turn it back to Barb to highlight just a couple of those findings.
Next slide, Molly. So I said that we were trying to understand value. So we talked to patients that have been exposed to movement. First of all, just to ask, what was it like, to be on a hospital unit where we're doing this mobility intervention? And, and we also, in parallel, I did another study where I was talking to just patients that weren't on this intervention site to also understand how they thought about the importance of ambulation during the hospital. So we were combining a very large data set to look at what patients were telling us. And patients consistently described that ambulation is important for multiple reasons. One of the reasons is it helps them maintain their health. They use ambulation to control their pain, to control their diabetes, to control their heart failure. Ambulation in the hospital was a way for them to be connected because they often felt isolated. They were admitted to a hospital, assigned a room, and they stayed in that room until they were discharged. So they felt very isolated and disconnected. So getting out and walking was a way to help them feel connected to the unit, the staff, and also to the outside world, because they would use windows to say, what's going on out there? What's the weather like? What route should I take going home to avoid this traffic? Patients also talked about the importance of ambulation because now they were feeling ready to go home because they felt stronger and more capable to then be independent at home and to recover. And that really correlated also with how patients talked about it was a better discharge. They were no longer afraid to go home because they knew they were ready and they felt stronger. So I think there's a couple of quotes here. Could you click? So I think this one quote just resonates for me. You're stuck in a room, getting out to walk helps with feeling isolated. So we now started thinking about, oh, this has some psychosocial components to it that we had not thought about and had not been explored in the data to this point. Next slide, Molly. We also, this was from our previous studies, we were looking at, well, how do nursing staff feel about getting patients ambulated and their experience with MOVIN? And it's fascinating that they all talked about this shifting their ownership. No longer were they waiting for physical therapy. They felt confident in their skills. So they were initiating and getting these patients up to walk, when in the past they would have said, nope, I'm just going to wait. They also felt incredibly supported with this intervention. So we had big buy-in from nurse leaders and nurse managers. And they felt like if the hospital organization was willing to provide an FTE, for ambulation aid, that this was critically important and they needed to prioritize patient ambulation. But also this move-in intervention started making ambulation visible, which is often something that was invisible on the unit. So it stimulated more ambulation occurrences that were happening. And I think we have a couple of quotes for those too. Yeah, I think this one, Move-In made me a better nurse, and that just makes me smile. How they were thinking about just their practice as a nurse and how this improved how they thought about being a nurse. And then the last slide on this. We also really wanted to understand value from a hospital standpoint. And this was data that we were collecting during the DNI Launchpad. Hospitals really talked about the importance of quality of care and outcomes for older adults. So that helped us think about, well, are there other data sources that we should be looking at? And right now we're looking at the HCAHPS to see was there changes that were happening during that time. Utilization costs were really important. So us being able to say that this decreases length of stay is going to be really critical for hospital administrators and leaders to think about, would they disseminate this throughout their organization? And a resource allocation cost, they thought a lot about that. So hiring ambulation aides and the cost of training nurses in psychomotor skills development, that is an expense. How do we handle that? They're really wanting to increase nursing staff satisfaction and well-being. So one of the measures that Lindsay and I and this team is looking at is what's happening with fatigue and measures with nurses when they're exposed to move-in during intervention and post-intervention to see if some of those things shift. And then also wanting to have good patient outcomes that were also alignment with some of the national initiatives. And this just came out that CMS is saying that they want to see hospitals provide measures for the 4 M's, which is age-friendly care. And one of those is mobility. So thinking about how do we best support organizations now to say, there are, where are the reliable and valid ambulation programs that actually will produce really solid results for organizations, for patients, and for nursing staff. And I think there's some quotes on that one too. There you go. If our HCAHPS scores are better, this will be important to us. So we are starting to look at that data now. Next slide. And this is yours, Lindsay.
Oh, okay. I thought we were just going to keep going. So we, next, to Barb's point about having some evidence-based interventions to offer CMS with their forums, we are in the midst, almost done, with a clinical trial testing the effect of move-in across 2 hospitals and 4 units, and how it impacts patients' functional outcomes. So in the past, we just looked at, did it change those nurse ambulation activities, those nurse behaviors and that culture on the unit? Now actually collecting the patient outcomes data, also looking at healthcare utilization and sort of a value assessment of move-in, bringing in some of that HCAHPS patient satisfaction data, and also physical therapy billing data. So we don't have full results on that yet, but we do have one slide just highlighting one of the key pieces of this. If you go to the next slide, is looking at an actual functional outcome measure for patients, which is gait speed, and collecting that as a key indicator of the effectiveness of move-in, not just on increasing ambulation activity, but on improving patient outcomes, coming back to Barb's original slide and this idea of hospital-acquired disability. So that's where we're kind of at today. The next slide just shows the last stage looking ahead on our journey. We have started some early work on dissemination across the state in partnership with the Wisconsin Hospital Association, and thinking about how to do more of that and ask some of our questions. If you go to the next slide, on how can we predict readiness for this intervention and support different organizations that might need different things to be able to implement it and see the same positive effects. And then further questions on, this is a 5-component intervention. How do you optimize and tailor that? Does every site need all 5 components? Do they need them in the same configuration? So lots more hopefully to come. But throughout this journey, if you go to the next slide, we have been so fortunate to have many partners. Two of the big ones are shown here, UW Health and Advocate Aurora Health as being our main clinical sites for this. And we really want to hear their voices. So I am going to stop and turn it right to Dr. Mary Hook, who will tell us a little bit more from the Advocate Aurora side.
Sure. Next slide. Can you hear me? Can you hear me?
Yes, Mary, we can.
Okay,
I had to
good.
come back off mute.
Oh, perfect. So, hello, my name's Mary Hook, and I'm one of the research scientists at Advocate Health. And I have been extremely fortunate to work with Lindsay and Barb on this study because for two reasons. One, I love research. And number two, I love when research makes a difference in patient care. So this has been just a partnership made in heaven as far as I'm concerned. So thank you very much for this opportunity. My part of it, I kind of tried to put together a little bit of information that if you are an academic researcher and you're thinking about reaching out to develop a partnership with Advocate Health or any of our other ones, it is a little bit more challenging. I mean, obviously we have a lot of patients, but there are a lot of things that we kind of have to consider when we get people involved. So I'm going to give you a few considerations for you to kind of think about when you go forward and maybe think about developing a partnership. The first thing from a research and evidence-based practice process, most hospitals participate in research because they have a need to develop information that supports that they are a magnet hospital. And I don't know how many of you are aware, but magnet is kind of like Joint Commission or, any kind of a place where you get a certain amount of criteria that you have to meet very frequently in order to be designated as something. Now, magnet refers to the idea that hospitals create a culture of really high-level professional nursing, and it's a magnet to attract other nurses and to give really good patient care. So our hospitals at Aurora Health, particularly in Wisconsin at the Aurora hospitals, we have a long history of being on the career track for being magnet hospitals. It does require, in order to achieve this designation, you have to do 3 research studies every 4 years to do the studies. And the requirement is that the hospital has clinical nurses who are involved as investigators. They also have a timeline that they have to have a couple closed studies and they have to have an open study when they come through to validate that you have criteria, you have met the criteria. So when you are thinking about doing a study or you're approached by a hospital that's doing magnet, thanks. Hold on one second. Doing magnet, you, just a second. I'm going to have to stop a second. My battery's going out.
Should we skip and have Sherry talk a little? I'm watching the time. I don't know.
I certainly can. If you want to go forward a few slides, I can stop you.
I'm back.
Oh, never mind. Sorry, Sherry.
Sorry, I'm
You
back.
were ready.
So what I was going to say is that these are the things that when you approach a hospital thinking about doing a research study, they are really needing to do research that meets that criteria. I'll also say that there are oftentimes competing priorities that sometimes when the leaders and the clinicians are on the unit, they do have a lot of things they have to meet as a service organization. So you really have to recognize that that's sometimes an issue. We also found out that units change their focus. And what happens is that, when one of our units, we started off planning that this was going to happen when we started our 5-year research grant. By the time we got to collecting data, the unit had changed their focus. So it is definitely that service environments are a little more fluid than what you might see in an academic setting. I'll also say that they really need a budget that is on a shorter timeline. So they're always looking for the next year or the next 6 months. So when we ask a CNO to partner with a project, we sometimes have to, talk with them about how do you budget in another year that we're going to need to share this cost. So it is definitely something you have to keep in mind. Next slide. I'll just say that Advocate Health started off as a Aurora started off as a Wisconsin hospital system. We partnered with Advocate in Illinois in 2018 and became Advocate Aurora with 32 hospitals. And now last year, Advocate Health became a 67 hospital system. So we are definitely getting bigger. Now, the big change with Advocate Health is that we partnered with Wake Forest Medical Center, and they are now our one site IRB. So that also does affect how we are doing, studies that we have to go through an IRB that's in North Carolina. So we just have some of those little complexities when we think about partnering for research. Next slide. I'll also say that we do have Advocate has a research institute, and they do all of our pre and post award. So we have all those things for contracting and oversight and all that kind of thing. But they often also do some restrictions on what they allow us to do. And they currently had a rule that we had to have only Aurora people approaching our patients. Now, in the past, when Barb and Lindsay, we did our first study, we had the ability to use students, but now we had to put that into the budget that it had to be an Aurora person that was doing it. So that really did affect how we were looking at it. Yes, thanks for putting that on. So the other thing then is we did have to look at how we do interventional data. Now, the exciting part is we did prep our data, and we did do a lot to make sure that our data was highly reliable and really working with our data collectors, but there was some training involved. I'll also say that we had some challenges trying to recruit patients. I will definitely tell you, trying to cover patients when you don't know if people are coming in or being discharged, that was really challenging to always be on call because sometimes they were unexpectedly discharged. We also have a requirement from the IRB that we have to give patients the ability to opt out from an approach. So that means our clinical people had to go in and say, can a researcher come and talk with you? And again, that sometimes caused a little of extra challenges because we had to work with the nurses a lot more than we would have expected. And then again, the idea of that trust and relationships that, oh, this patient's going home. Oh, we'll be there in 20 minutes. Can you hold them? So that we learned a lot in doing that process. And again, the idea of unplanned discharges and unplanned transfers made the data collection a little bit more challenging. Next slide. I will kick it off then to say that Sherry's going to talk about the next part about her unit.
So hi, everybody. I'm Sherry Martin. I'm the manager at St. Luke's Medical Center on 10T. Again, like Mary, she gave a good background on our hospital. So we have 938 inpatient beds here. We are recognized for many of our different specialties, such as 24/7 cardiology, advanced heart failure care, organ services, cancer care, stroke, neuro, spine care, our wound care and hyperbaric care. We're also known for our nursing shared governance. We've had nursing shared governance here at St. Luke's Medical Center since 1984. And again, Mary gave a good background there about our magnet status. So we achieved our first magnet status back in 1999. We were designated with our 6th recognition this past year. We are now in an elite group of hospitals that have a 6th designation. We're one of 20 hospitals out of 599. A little bit about my unit. For when we began our moving journey, we were the second of 3 units here at St. Luke's Hospital that went up with the intervention. So I did have a little bit of prior knowledge about hearing what it was like on another unit, but I did not know all the intricate details of it, or how I was going to lead my team into participating. Our unit is a very high acuity, fast-paced unit. We specialize in electrophysiology, advanced heart failure, and pulmonary hypertension. You go to the next slide. For unit participation, we really had to start focusing on how we were going to get the buy-in of the team. We were coming right out of the COVID pandemic, where we were hitting our nursing shortage, where we had high turnover. We had a lot of brand new nursing team members. We had lots of different changing things happening where the team was burned out, working long hours, picking up extra shifts. And we started it by, again, looking for those volunteers and asking for people who would volunteer. We started with creating a launch team. Our launch team was 2 nurses and 2 nursing assistants, supported by both Barbara and Lindsay and me and Mary Hook. And we did frequent meetings right from the beginning to get to know each other, to make connections, and to come up with a plan. You can go back one more slide. We were very open to who wanted to be on the launch team, but we also had to do a little bit of encouraging. And so we made sure we had coverage that for both night shift, for weekends, for during the week, by our team members that were working the different shifts. Another part that we worked through was that psychomotor training, where they had that hands-on and classroom with a physical therapist. Again, we had to look out for nursing volunteers, and that took a little bit longer to get our list filled than we expected. But once we started getting a few volunteers, we got the word out, we got the encouragement, and they were finally able to get that going. Setting up the schedules for that was, again, a little challenging, as we were already going through that staffing shortage, to be able to pull them off the unit for these classes, as well as to have those one-on-one sessions with the therapist. But we were able to make that work. And then for staff survey, we had a survey both pre and post. You know, again, as the first time me leading this on my unit, I thought, not a big deal, people will complete the survey. What we found out with the first survey, it was very lengthy, and the team brought that feedback, and we were able to make changes. I believe we also changed it to an online survey so that we had both the option of doing it on paper and doing it online. Effective strategies, right from the beginning, we started with our leadership support here at the hospital, from our chief nursing officer to our nursing director, to myself, with really making sure that we were being supported, that we were making sure we were recognizing the team for what they were doing, being involved in our planning meetings with the UWM partnership. Our meetings started well before intervention stage. I felt very prepared to lead the team by the point we got to our actual intervention. The planning meetings also helped with allowing the team on my unit to really make it personal, make it their own, be creative with the way that we were going to be implementing it. And through all those planning meetings, both UWM partners were here on site many different times, whether dropping off materials or on virtual meeting calls, that they did get a chance to know the nursing team on the floor. You want to go ahead to the next slide. So kind of overcoming some of our barriers. We look at this by, you know, the barriers we had just with our unit operations of flow, the barriers we had with patient involvement, and the barriers we had involved with our nursing team. When we're looking at our, you know, like the unit operation and flow, again, like was mentioned, you know, the culture on the unit did not prioritize patient ambulation. The nursing team, you know, focused on activity. What is the patient's activity? How do they move? But putting the ambulation as the main priority was not happening. Also, limited resources that we had. We didn't have markers in the hallway identifying how many feet we would be walking. So when nurses were documenting the activity that they were doing prior to the study, they were guessing how many feet they were walking and didn't have that clear accuracy of how many feet. We also did not have walkers readily available for all patients in all rooms. We found that our whiteboard wasn't maybe the most patient-friendly to focus on mobility. And then again, just those competing demands, really focusing at our nurse-sensitive indicators and the quality of care and patient experience. And then new nurses just learning how to do their assessments, pass their meds, complete their tasks. Mobility and ambulation was always falling to the end. And then we also had the limited communication. So during the post-COVID, we were not having staff meetings in person anymore. We actually weren't having many staff meetings due to the short staff of the unit and really needing to make sure that our team was working, or if they weren't working, that they were taking time for themselves to prevent the burnout. When we did start picking up meetings again, we were doing just virtual meetings, relying heavily on emails and printing out information that we would leave out for the team. When we look at barriers for our patients, again, like was mentioned with their previous experiences, patients were just used to staying in bed the majority of their hospital stay, maybe getting up to the chair for a meal, but that was kind of what was normal to our patients. We also know that our patients are having more medical conditions. They're weaker, they're more short of breath when they're here. They have catheters and central lines, and they don't think they can get up and move with those things. We also know that, we talk about safety precautions. We don't want our patient to fall, so we just keep them in bed so that then they don't fall. And again, then patients feeling that isolated, not being connected to the team. And then patients having a sense that staff are just too busy. When we look at the nursing team, again, they were having higher workloads. They were working those extra hours, extra shifts. They weren't having the confidence of how do they move their patients. They were usually waiting for therapy to come the next day. So with that 2-hour, I think it was a 2-hour training class plus the one-on-one time with physical therapy, they started getting comfortable realizing how could they move a patient and not injure the patient and not injure themselves. And then again, with focusing on fall prevention, that first time out of bed and how nursing can use, CMET to really evaluate how a patient moves so that they can start moving them sooner rather than waiting for therapy to come. You can go ahead to the next slide. For unit engagement, this is where we brought the fun into moving on our unit. So definitely the way that we got our team all on board and engaged was having presence on the unit, whether that was presence by me as their leader, presence of the UW team stopping on our unit multiple times, or from our CNO or our director, or other people in the hospital who heard the buzz about what was happening on our unit. It really got the whole team engaged. Again, like I said, we just really kept that buzz going. We were listening to the team, hearing what they needed, hearing what suggestions that they had, and making sure that we included them in those fun ways. So we did create a few different themes throughout the time frame that we were doing our intervention. If you want to go ahead to the next slide, there's a picture on the right side, which one of our themes, we made it like a racetrack. We had our little moving guy at the top in the center. And as we set our goals, and we did mileage goals, and we set a timeline of 1 month, we would move our little moving guy around our track, and we'd get to 25% or 50% along the way. Just really sharing those milestones with the team. And then when we achieved our goal, having a celebration around whatever the theme was. So we did different themes like the Milwaukee County Zoo. We did themes like Apple Holler, Lake Geneva, Chicago. And then we would celebrate with whatever that theme was. So when we did Chicago, we celebrated with Chicago style pizza. For 4th of July, we celebrated with ice cream treats. So the picture down there in the middle is one of our team members grabbing treats from the freezer. This worked for my team because my team likes snacks and food, and that's how they like to be recognized. For some units, that might not work. For mine, having these creative ideas and themes worked. It was also something that they shared with the patients. So usually the patients knew what the theme was of the month when they were here. And this board was visual for all team members to see, as well as any patients that were walking around the unit could also see our display board. I also wanted to say, like, a huge part of our success was some of the other fun things that we did to promote moving, such as we called them our moving sneakers, which were just little pieces of paper that had a little sneaker shoe on it. And if you walked your patient in the hall, you could write your name on it, put it in the ballot box. And then every week we were drawing for names. And again, rewarding them with gift cards, moving socks, which were a big hit, and other local gift certificates. We also did something where we would say, if we caught you moving, we would give you a snack. And that's where we pass out a granola bar, a bag of popcorn, a candy bar, different things like that. And we made sure that our moving team had those treats so that team members on all the different shifts and during the week and on the weekend could still be recognizing in the moment we caught you walking.
Sherry, this is
yes.
Mary. I know we only have about 5 minutes left, so I'm going to have her skip ahead to the next 2 slides,
Sure.
and I'll cover them real quickly so we can answer some questions. I just really want to recognize that as Barb showed on one of the previous slides, we did look at percent of nurse ambulated, how much the physical therapists were ambulated, and how many people weren't able to ambulate at all. And you can see the blue lines are the nurses. And we started off at 67% of the time nurses were ambulating the patients, or 67% of the patients were ambulated by nursing. By the end of the 1 year mark, there were 85, and it was very consistent every month. And you can see that as the nurses did more ambulation, the physical therapist percentage went down because they didn't need it. Similarly, on the distances, you can see when the MOVIN study started with a full-time FTE person doing ambulation, the distances skyrocketed from 8.2 miles a month up to as high as 80 to 90 miles a month, which is insane that the nurses were able to do that. Now, with COVID and the Omicron surge and all the rest of that, there were some definite challenges, but you can see that even as we had some staffing issues and eventually the ambulation aid wasn't still there, the nurses on the unit and the aides on the unit picked up to maintain that over the year, which was just stellar. Now, after 3 years, next slide, Molly, after 3 years, we can say that, go back to, I just want to show you that it's Sherry's unit has been phenomenal. The blue line in terms of percentage, ever since MOVIN started, without an ambulation aid, they are at 80-some% consistently. And you can see, again, therapists are seeing about 30% of the patients on this cardiac, advanced heart failure, EP study kind of patient population. Now, there were some challenges in terms of distance ambulation because those ambulation aids were about getting those people out in the hallway. But as we've been able to be successful getting the intervention done, we've really seen that her unit has been able to achieve even higher lengths. So I just need to hand it to Sherry because her leadership has been unbelievable. Next slide. So I'll just close with saying that at Advocate Health, MOVIN has had unit-based impact, but we've also put it out there for the whole system. It's been instrumental in getting reports and all kinds of things done, a mobility wheel that we train all of our nurses on mobility, and it's really influenced our system-wide efforts to be age-friendly and to get patients mobile. So this has been research into practice, and it's had a big impact. So last slide, I'll just let Barb kind of tie it up.
So I feel like we blasted you, and we've been trying to answer questions in the chat as people have posted this, but we have a couple of minutes left. Anybody will open that up for any additional questions. So I don't see any more coming up. I have something from police. Just to, in this closing minute, ask that all of those in attendance, please take the time to complete our survey about this presentation. We track this data, it really helps us looking at our metrics and what additional types of presentations we can provide through DRISS. I think what I'd like to say is this really, to me, represents the D&I cycle of how integrating the critical need for our partners in design, and then looking at not only can we implement, can we disseminate, and can we sustain, which is what's critically important in promoting patient function. So with that, it is exactly 1 hour. Thank you for attending today to this presentation. Thank you, Mary and Sherry, for being part of this presentation. We greatly value our partnership and our ongoing efforts to improve patient outcomes.
Thank you.
Thanks for having us.